Human factors, and if you were in our previous sessions, we talked about human factors then. We'll talk about it now. We could talk about it later. There's lots in this topic, but what we'll review is a little bit of definition on human factors and some particular applications of how this, why this matters when we're working with through intervention design, change agents, that sort of thing. So there's a particular focus there. What is human factors? It's a science. Science of designing tools, tasks, and information systems so it's compatible with the abilities of human users. And we're talking about mostly the cognitive abilities today. I'm going to give you a little historical review. So to a few of you, this will be familiar. To others, this will be an interesting, hopefully an interesting new perspective. This is a little bit out of date, but it was a turning point for our work. This was at the beginning of what has now become the patient safety movement. Was a report from the Institute of Medicine in 1999. It came out. And that report said that as a result of studies in New York and Colorado and Utah, it looks like between 44 and 98,000 Americans die every year as a result of medical errors. 2 days ago, there was a report in the BMJ, that says they got it wrong, that it's 3 to 4 times higher than that. And hasn't come down significantly since 1999, except for apparently some reduction in infections, inpatient infections. One of the reasons that one of the differences between these numbers and the later studies were actually, this study didn't include infections, or at least didn't count them very well, and diagnostic errors weren't captured very well in that either. So they said 8th leading cause of death in 1999. That was controversial. The report that came out 2 days ago says the 3rd leading cause of death. Okay, so what does this mean? You come to you read this. This was big news in 1999. And when people hear about errors and deaths, what do you think? You think that somebody isn't doing their job. You think that somebody's incompetent, careless, uncommitted, or greedy. And this interpretation of error is actually a subject of study in this field. And this interpretation is called the fundamental attribution error. That is when some bad outcome happens, some unwanted outcome, that we have a tendency to blame the people involved. There's another point of view. Now, this was in 1999. This was a big deal. Even talking about medical error, patient safety, was a problem, and I did. I talked to a lot of folks. We talked to a lot of folks, and I talked to doctors and nurses and pharmacists, and they know how hard they work to ensure patient safety every day. How hard they work to prevent errors or to capture errors, and they know that they know they're surrounded by caring and careful people. They're skilled, they're educated, and they're competent, and they concluded that if you have good people, they can't be producing these kinds of bad outcomes. That's incompatible. And they made a mistake, I would suggest. The idea here is, and this is another thing that's studied, it's called the fundamental surprise error. The failure here the error here is in failing to be surprised, to recognize that maybe one of our assumptions is wrong. Maybe good people won't rise above bad systems in all cases. Maybe we got to fix the systems. So this is something that was a curious point of timing, right when when this report came out in 1999. There was something going on in Salt Lake City, Utah, that served as an interesting example. That's where, I didn't mention that. That's where I'm from, our Salt Lake office. Anyhow, I didn't give you a clipping from the newspaper, so you'll trust me on this. I-15 runs not only through Las Vegas, it runs through Salt Lake. And in 2000 or 2001, well, in the years preceding 2001, they were rebuilding it in the middle of downtown Salt Lake City. It was a crazy time in Salt Lake. Leading up to 2001, it was exciting times because Salt Lake City was going to host the Winter Olympics in 2002. So, we're going to have all these international visitors. We're going to have, athletes. We're going to have a corrupt French figure skating judge, all those sorts of things. So we rebuilt the road, and it was a mess in town for years. When they're rerouting the freeways and you get on there and they're closing exits and things like that. And the airport's on one side of town. I lived on the other side of town. I never knew when I'd come back from a business trip which way I'd have to take to get home. It was crazy. But all those good times we're putting behind us because it was the spring of 2001 and they're grand reopening. The freeway is back in business but there was a problem. People were going the wrong way up the 4 South high occupancy vehicle off-ramp. Let me show it to you. So this is close to downtown Salt Lake City, Utah. This is I-15 north, the same I-15 that you've got. If you drive far enough, you'll end up going up that way toward Idaho. And in Salt Lake, here's Salt Lake, and lots of people want to go on I-15 south at the end of the day to go back home. And this is a carpool lane, and this is the arrow they should have followed. Should have gone there, go south on south, but instead, they're going south on northbound I-15. Yikes, right? They're going this way, they're doing this in spite of this. There are arrows painted on the road. There's a sign. Wrong way, wrong way, wrong way, right? And eventually they put up one of those concrete barriers, and people were trying to drive around that thing and go up the wrong way. And it was crazy. The Salt Lake Tribune article about this says, naturally, motorists entering the wrong way on a freeway would be in for a dangerous surprise. No fooling, huh? So that's why I buy the Tribune, for that kind of in-depth analysis. All right, so that's bad news. This is not what we expected when we built this road. So what are we going to do? This is an unacceptable situation. How are we going to fix it? Well, this is Salt Lake City, Utah. We know what to do. We gave people tickets. We wrote tickets to people that went up there, right? They violated the law. They're not supposed to go the wrong way on the freeway. They gave out 30 citations in a few minutes. In a few minutes. They switched over to warnings. I think they ran out of the ticket book. Switched over to warnings. 145 warnings in less than 2 hours. So right there we have nearly 200 people that made a potentially fatal error. They switched it over to warnings. They closed the off-ramp altogether. I have an assertion that this is a design flaw. Well, let's test that assertion. You know how they tested that assertion? They went out and they talked to the engineer who designed the road. I guess what the engineer said. They said, there's nothing wrong with my road. People aren't paying attention. That's the problem. It's the user. Okay. All right. So let's take a deeper look. If it's a design flaw, we should be able to find some design features that explain it. Right? This particular intersection or interchange is unique in Utah. The ramps enter and exit on the left side. There's no other place in Utah where that's the case. Now, here's what I think is more important. For over a year and until just very recently, you know how when they're building a freeway, they use the lanes in funny ways? They'd been using the off-ramp as an on-ramp. For over a year, they trained people to go up this thing, right? So eventually, what they did is they redesigned this interchange, this intersection with a longer median. What they did is there's a median here, and they made it longer. Before it was shorter, so it was, and actually you could go faster, but that's not allowed now. But you can go there, and you can see it. It's there today. But you'd really have to now to get this on there. It'd be like doubling back. It'd be an unnatural act of driving, and even in Salt Lake we don't do that. So they fixed the system, and it works. Let's see. So why did we bring this up? We use this as it has contrast and parallels, has some principles for change agents and learning from error and that sort of thing. Just quickly here. So first thing we did with the I-15 example is we sought to punish the offenders. We gave out citations and warnings, and it didn't work. Why not?
Doesn't educate everybody else.
Doesn't educate everybody else, right?
You're asking people to change a behavior that was perfectly normal before.
Okay.
It was unintentional.
It was unintentional. It was unintentional. So remember, this was a carpool lane. So everybody had a passenger with them. And among the 200 people that went up that off-ramp, not one of them said, "Hey, watch this." You know, I know a shortcut. I hope there are no cops around. Not a single one of them meant to go the wrong way. They're just trying to get home. It was an error. Punishment doesn't work on errors. It doesn't educate the next guy either. It's that sort of thing. Yet this is and remains, unfortunately, I believe, the primary response to errors in healthcare.
HealthInsight was born.
That's right. So what happens? So people, and now this is not a trivial error. I mean, this is an error. People were making an error. Most of them were just following the guy ahead of them. Most of them have been trained. This is the way I've been going home for over a year. But you know, you're a driver. You're supposed to pay attention to this. So, but it's serious. But then knowing how serious it is doesn't fix it, right? And in healthcare, we have serious consequences for that's why we need professionals, right? But punishing doesn't work for the same reason. If it's unintentional, this doesn't get at it. So we actually used this story quite a bit. Early on, this was early in our patient safety work. This is early in the patient safety field. Deborah used this example at a testimony to a legislative committee to try to help them understand why we need a statewide reporting system for this. Why are we doing this? So this is an example of the type of information that we use for change agents. This was a safe example. Two things: nobody died, and it had some useful, obvious messages in there, and it wasn't in healthcare. So it helped our change agents reframe their experience and say, you know what, I understand why blaming people for error doesn't work here. Maybe what we're doing over here doesn't work. So that's what we were seeking to do with that example. And then there's another element that I want to be here. So we tend to be, as HealthInsight, we're in a position where we could be like the engineer and in some sense blame the user. And so let me explore that for a minute. A couple of things. I'll just tell you some case. Well, let me I'll explain to you an experiment. This is a social psychology experiment. There are 3 participants in this experiment, and they are randomly assigned. One is assigned to be a questioner, one is assigned to be an answer, and the third is assigned to be an observer. Okay, you take groups of college kids and others, and they know that they've been randomly assigned to those roles. And then the questioner, it's like they're supposed to be like Jeopardy or a game show. They're supposed to make up some trivia questions, stuff they know. And they're supposed to ask the answer, the questions. And they're supposed to be interesting questions that the person may or may not know. The observer just watches this whole sort of thing. So, and then, but that's not so the experiment, so you get it so far, you're randomly assigned to one of the roles, you know you've been randomly assigned to that role. If you're the questioner, you make up questions and then you ask the other person. If you're the answer, you try to answer them. So, and then they do it. They 5 questions or something like that. And then, and you can imagine that the person being asked a question gets some wrong and some right. Right? And then they ask each of the 3 participants, which of the 2 people is the smartest? The questioner or the answerer? Okay, so what kind of information has the observer gained from this experience? Remember, they've been randomly assigned. So if I'm the questioner, obviously I'm going to ask about stuff I know about, right? And whether the other guy knows about it, that's not a very good indication of their intelligence, right? So you would think on average the questioner and the answerer would be judged about equally intelligent, right? Except they're not. Systematically not, worse than that. The observer, the questioner, and the answerer all rate the questioner as more intelligent than the answerer. Even though everybody knows this is an artificial situation. Okay. Why do I mention that experiment? Besides, it's interesting. Our position makes us subject to underestimating the capabilities of the providers that we work with. In this manner, we interact with them on kind of a narrow basis. If we want to talk about depression screening, for example, that's the only thing we're talking about. And if we want to talk to them about it, we've identified them as somebody that's not doing it. We are at risk of using that tiny bit of information to make more global judgment of their capabilities, and we have to be careful about that. The people that we're working with are competent they're fully competent professionals. Just the fact that they stay in business means that they know something, they know how to do something. And if we are insensitive to that, if we allow the position that we're in to influence that, then we lose our effectiveness. 2 things. We lose our effectiveness, we can't connect with them as well as we should. And 2, we fail to appreciate their strengths. That's what the solutions are always going to lie with our providers. And our job is to recognize those strengths in the provider. And our perspective puts us in, or our role puts us at risk of underestimating that strength. Let's see. So regardless of this is an idea that comes out of, regardless of what the situation, we need to understand that our customers, our clients are doing reasonable things given their goals, their mindset, their understanding of the situation, their mental models, that sort of thing. Even if they're not producing the outcomes we prefer, it makes sense. Whatever they're doing makes sense within the tunnel, if you will, of their of their world, their goals, those sorts of things. It's up to us to understand that. Let me give you some applications of this sort of thing. So recall this example. Again, ACE inhibitors were especially there, since, in fact, this is an old example now, there's another class of drugs, ARBs, that are used, but at any rate, at this time, the ACE inhibitor was a treatment that was indicated for some patients with heart failure. It wasn't used consistently. This was one of the first times, by the way, 6 scope of work with the Quality Improvement Organization work was the first time that there was a standardized evaluation throughout the country. We're all going to be evaluated on the same metrics. I think the performance, I think it was around 60% of the patients identified that were ideal for this treatment were actually receiving it at the time. We had, the way that the data source we had for this was medical record abstraction, and we had a data set that showed what the rate of that application was. There was actually one other interesting thing we could pull out of that. Some physicians, so this is a random sample, and some physicians had more than one admission for patients with heart failure. So if I'm looking for a leverage point for increasing the use of this drug, one theory is I can find all the doctors who aren't prescribing it and go talk to them. There's a model for that. It's called academic detailing. It's actually quite successful. One of the problems I had with that is for when we saw physicians with multiple admissions for patients with heart failure, whether or not they prescribed it for their first patient was a poor predictor of whether or not they would prescribe it for their second patient. That is, their behavior, their prescribing behavior was inconsistent. That's a problem. That was one problem. So I thought, well, I can't find, it's just not one guy that's not doing it. It's everybody's not doing it sometimes. Yikes, that's a lot of doctors to talk to. Okay. And it's a lot of doctors to talk to. There's another thing that we identified. We talked about this before in the logic model. We said, okay, maybe this isn't the only place that we could intervene. In principle, if the way that we get to reliable systems is by tying together components, is there an opportunity to detect and correct this problem? And we've done some review. And we'd identified that at least in principle, that a physician not ordering something can sometimes be detected and corrected by a standard process that's been implemented, by a pharmacist. In fact, that's one of the primary jobs of pharmacists, is to identify problems and correct them, or by nurses on the unit. Any one of those is actually a potential capture opportunity. Actually, I've got in very light thing, there's even other, what would be another capture opportunity?
Family members that may have read ask the doctor about it.
That's right. That's right. I will confess that we didn't include that in our analysis, but that's a legitimate. The patient or family members can also prompt consideration or something like that. But this is our analysis. We said, well, maybe we can find out whether these sorts of things can be called into action here. So when we looked at this, and 6 scope of work was a 3-year scope, and other reasons, here's what our analysis was. First of all, our analysis was with a physician, just to back up. Okay, with this failure mode, this was tough. This is 1999. There are fewer hospitalists than there are now. So these are some cardiologists who, by the way, were almost always getting this right. And there were a lot of internal medicine docs and family medicine, and there were a lot of them, hundreds of them, that we would have to get to impact this outcome. And they were doing it some of the time, but not at an individual level. They're doing some of the time, but not all the time. So it wasn't like they'd never heard of this drug. They're just using some other rule for when they used it, a rule we didn't understand. So a lot of them, their behavior was inconsistent, that sort of thing. So we're interested in this capture because we could find in Utah, for example, we could get to 90% of our admissions in 17 hospitals. So these look like a more manageable group to get to. So what do we do? We reviewed, we said, well, okay, standard process. If you already have a standard process, let's just see if it's got, does it have the drug in there? Is it part of it? And if you have a standard process, are you actually using it? Anybody actually using it? Because if we like this as a solution, develop a standard process. The problem is it takes a long time. And so we thought, if they've already got something, let's see if we can enhance that. And then, so that was one of our strategies. The next strategy was the pharmacist. Now the pharmacists, we talked to them, and this is 1999, they said, we'd be happy to do, we're eager to help out any chance we can, but it's hard for us to know the diagnosis of these patients. So, we're not really in a good position to do this. Yeah, okay, all right. Then we talked to the nurses. Our change agent, here's our change agent pathway. We typically in hospitals, we connect with the quality department. We asked the quality department, can we set up some meetings with nurses in the units, because there's only a few places where heart failure patients end up. Units where most of your heart failure patients end up. So we did. We set up meetings with them. We found out the nurses were willing to prompt physicians to consider treatments. We found out that's part of what they do. They were in a good position. They knew the patient's diagnosis, of course. There was some concerns that in some hospitals, it was a bit of a mixed bag of what the nurse's role was. The nurses can highlight, if the place is on fire, they can yell fire. But is it okay to say, doc, did you consider ACE inhibitors for this patient? There's some places where that was okay, and other places where it wasn't. It was a curious thing, but there was enough places where the nurses said, yeah, we can prompt that consideration. They said, here's the problem though. The doctors are in and out. We never know when they're coming. I can't chase them down. So I'm not sure I'll be able to talk to them. And I don't want to put a note in the medical record. Okay, so that was a barrier. So what we ended up doing was Jackie remembers this. Do you remember? Maybe you don't remember.
I remember the project, but I am trying to remember how we got around that.
We printed up sticky notes.
Those notes.
Sticky notes, right?
I have something to copy them.
We still, really?
Yes, I think we did.
Because the sticky note, they said that I could be bold enough, because the doctor can wad it up and angrily throw it away if that's what they want to do or whatever, but it doesn't become a part of the medical record. So it was an action that they could take. It was consistent with, at least in enough hospitals, it was consistent with the cultural norms. It was easy, and it was effective. And it was effective, I'll talk to you about. So that's what we did, not just for heart failure, but for other projects. And this is when we actually implemented it more in Utah than in Nevada, truth be told. And this is what we got. In Utah, we saw it was about almost 3 times as much improvement in Utah, and a big gap in between us and the next state. This is standardized measurement throughout the country, and the point was we didn't work harder than anybody else. In fact, we didn't. We didn't ask them to form teams. We asked them to, literally, we met with people, we said, we identified a high leverage action, at least what we thought was a high leverage action. We talked to the people that were in a position to implement it and confirmed that that worked for them and solved that problem of how do you implement that. That was our primary change, and it worked. It was substantially better than all of us were highly motivated to try to move this sort of thing. So what were the human factors involved here? We identified this as a potential, potential leverage point. We could try to get to every physician. But the problem was that there's too many of them, and they're using, we think, there wasn't like the guys that weren't doing. We just had to find the laggards. It was the inconsistent use of it. So we thought that they weren't really anti-ACE inhibitor, so that a prompt, just a nudge, would be enough at least to move it substantially. And it was the same intervention, not just for ACE inhibitors. They're actually the same sort of thing for AMI, for pneumonia, that sort of thing. It was the same type of sticky note type of interventions.
And wasn't this the precursor to the big three, right? The execution.
Yes.
Right.
Yes. Yep. So let's so applied behavior analysis. So and we'll tie this sort of thing together. So there's two types of behaviors that are worth, let's see. It might be useful to sometimes think of behaviors being as trying something new. It's one class of behavior, something I've never done before in my whole life. I'm trying something new. Or a persistent, repeated, habitual behavior. In trying something new, when one is offered, and this comes up, change agents, we're presenting them with an idea. Let's try this. Will you participate in our project, and that sort of thing. Most of what we do is described by this model. This is called the recognition prime decision making model. Pattern matching. Most of what we do is use our prior experience, our mental models, to understand the cues in a situation. We match patterns and activate action. We're not inventing new solutions all the time. We're instantaneously responding to or reacting to the cues presented to us. And this works really well for us. Most of what we do is described by that pattern matching. There's some interesting work that suggests that subtle ways in which we frame a question, the cues that we present may activate different action scripts. Folks sort of study behavioral economics. A lot of that is getting to just subtle ways in which we present things impact behaviors. But in this case, I want to talk about persistent, repeated, habitual behaviors. Everyday behaviors that are repeated are one of the findings from what's called applied behavior analysis that we'll talk about, is that those types of behaviors are driven by consequences that the actor experiences. Immediate, dependable, positive consequences are the strongest predictor of repeated behavior. Soon, certain, positive is the way to think about it. If a behavior is repeated in a workplace or anywhere else, expect that there is something in the environment that is reinforcing it. Okay, so if one of the things that we're working on, if we see shortcuts, workarounds, that sort of thing in an environment, we should suspect that there is something in that environment that is reinforcing that behavior. And that's a powerful thing. It will continue. That behavior is likely to continue as long as that is true. If we want to change that, we can seek to introduce new positive consequences for the desired behavior. Those consequences can be feedback and beyond. And here's something of an update that I want to explore with you. Intrinsic motivation is a strong and persistent positive consequence. So when we think about consequences, often we think about external motivators, the things that one puts upon people to motivate them. Let me explore this with you for a moment. Everybody can be honest here. We're in this. We're here, and we're just talking among colleagues. How do you feel when you're on the freeway? If you and the traffic allows, where are you in relationship to the speed limit? You have a comfortable place. Well, I will tell you that where my behavior is 3 to 4 miles above the speed limit. How does that feel? What about?
Not quite high enough, but it's over the limit.
Okay. 3 to 4. That's okay. Everybody has kind of your set point. Okay, you don't have to confess what it is. How do you feel when you're below that set point?
Anxious.
Feel anxious.
If I'm driving the speed limit on the highway, it's free, I'm anxious.
Right.
Like I need to get there fast.
Do you ever go above your set point?
Yeah.
How do you feel then?
I feel like, I better slow down. Like I feel like that there's going to be a consequence if I go above my set point.
Okay, so here's the way I express it. When I go above my set point, I feel anxious as well. When I go below my set point, I feel anxious to a different type of anxiety. But it feels like, if I'm down right at the speed limit, that doesn't feel right. And if it's at 8 miles an hour to me, that doesn't feel right. Guess what? That's a consequence. In fact, that's the consequence that's actually driving my behavior. Is how that feels. And it's right then. As soon as if I'm speeding up to pass a guy, because I want to get in front, it's certain. It's me. If I can see the speedometer, it'll happen. And if I'm in the right spot, it's positive. And that's now there are other types of consequences. But for the most part, or one of the things that we can leverage is intrinsic motivations as a motivator. So let me give you just a couple of quick examples of motivators, examples of sort of things. It's funny because some of you will recognize this first example, but or a parallel with this first example. Atul Gawande talks about some work that they did, that the U.S. Army did, on reducing blindness among soldiers deployed where they use a lot of the... Are you familiar with this story? What was the story?
So there was a lot of blindness being happening because people weren't wearing their eye protection.
Right.
And the reason that they weren't wearing the eye protection was because it was ugly and cumbersome. So just by changing the design of the eye equipment, they had more soldiers were able and willing to wear it.
So we're having soldiers going blind. These are soldiers that have to follow orders, right? These are civilians, have to follow orders. They're being blinded by these improvised explosive devices because they felt their goggles made them look like grannies. and so what are the options you have to, and yet, what are the consequences? It's your own darn eyes. You know? I mean, how much more palpable can the consequences be? And yet, what was driving the behavior was the anxiety about how I'm going to look wearing these granny goggles. But rather than fight that battle, they just bought some new goggles. Right? And then there's a lot to be said for that. We will not be able to find higher extrinsic motivators, outside motivators, than guess what? You get to keep your eyes. So we need to be looking for those types of solutions. How can we? There was I had the opportunity to work with a hospital. I won't provide more detail from it. We were called in. They had a case where unfortunately a patient had been killed through they had a transfusion error. They transfused the wrong type of blood. As we were reviewing this, we turned this as a relatively small hospital. There were 2 technicians that worked in the blood banking system there. And it was known that if today was the day that technician A was working in the lab, it might take a while before you get your blood. It just takes longer with this guy. Technician B, he gets them out like that. And guess which one they liked? Technician A or B? They loved Technician B. It came out just like that. Until they killed the guy. Because Technician B is cutting corners. And he'd been cutting corners forever. And it was knowable. Nobody ever asked, gee, I wonder what's going on. Actually, no, they assumed Technician A is just dragging his feet. Nobody ever wondered about, so what type of feedback was Technician B getting? Positive. They're thanking him for cutting corners. They didn't know it, but they could have been suspicious about that sort of thing. One of the things about this sort of understanding the effect that consequences have on behaviors is that shortcuts are persistent. It's rare that you get the transfusion error the first time you try that shortcut. Usually it's a well-worn path, and it's identifiable, and it's not Technician B. It's the system that set it up that we have to address. So, where do I want to go here? Okay, so talking about change agents. Let's review this a little bit. Okay, so here's some logic principles that we're getting to with change agents. So today we're talking about designing interventions. And in some sense, we identified that interventions are, I suppose, information that, well, it includes information, includes change agents, includes actions. Let's see if we can tie those together. So the design challenges, I think, involve, we have to answer. We got to identify who the change agent is. Okay? Now, in some sense, we don't get to choose in every sense. So sometimes it's like, okay, so you're the change agent I've got. What can we do together? It might not be the ideal. But in some sense, we've tied that idea of the change agent to an action. So they have to be, a change agent has to have the means, the motive, and the opportunity to take some action. What do you think about means? Means to take action. How would I know that somebody is a change agent? How would I know if they have the means? What are
resources?
Resources, okay. Ability, okay.
They also have to have a certain they have to have a certain presence in their organization.
So either a formal leadership position, right, either through position or through influence, or even from the ability to discover that in the course of this, but it's got to come from somewhere, right? In some cases, we will find in some cases, this is the experience by which they gain that status. Okay, let's talk about motive. What do we think about, how would we know that somebody has a motive for promoting an action that we're taking? What types of motives? What are you thinking?
Make their job easier or streamline their resources.
Okay.
Personal motivation.
Okay. The personal motivation, they want to make our world a better place. Very good.
Potential rewards.
Okay. Now, good news. We're in healthcare. We're working with healthcare providers. They have really good motives. Start with. We should be able to align. And then opportunity. I think it's close to means, isn't it? So it certainly has to do with resources and those sorts of things. So we have some connection between, now keeping in mind that one of the actions, if you will, an action that a change agent might take, in fact, that might be their only action, is to recruit the next guy or to recruit a team. They don't necessarily have to do everything on their own. But we have some sense of where this action is taken. We know from our earlier work that there's a patient all the way at the end of this, and there's something that impacts that experience. So we have some sense of the range of actions that might be necessary. All right, now this is our process. If we could identify a change agent that has some connection to reasonable actions, here's the kind of things that they have to, here's their tasks or steps that they have to attend to our change message. All right, it's a design challenge. Change agents, what do we know about change agents? Well, they're going to be, if they're that valuable, they're going to be busy people, right? They've had a lot of people tell them a lot of stories about how they should change their lives already, right? This is their first day, and they've probably been burned once or twice. They've probably used or heard the phrase "flavor of the month" before, right? Okay, so here's our challenge. Here's our design challenge. How can we don't believe? Here's a logic model. This won't happen, I assert, unless this happens. Any concerns about that logic? Okay. And how can we increase the likelihood, or what's our design? What kinds of things do we think about when we think about attending to a change message?
Be repeated enough that it sinks in.
Okay. So we may want to design a information campaign, if you will, that presents different circumstances in different ways to a change agent, this change message. Okay? What else? We got to get their attention.
Their return on investment.
Okay? So the content of the message emphasizes a return on investment. Go ahead.
Expected outcome.
Okay.
It has to be phrased in a way that's going to promote action.
Okay. Okay. How are we going to deliver it? How are we going to deliver this message?
For some people, interpersonal
So
better than printed message.
right. So although maybe within the context of what you talked about, again, multiple sources repeated, that sort of thing, right? What's that?
Peers.
From peer, if they can get somebody else to promote the message as well, right?
Another doctor.
Right. Okay. This is design. I mean, one key trade-off. People attend to people that are sitting, more or less, sitting in the same room with face-to-face, that sort of thing. People attend to one-on-one messaging, more or less, and that sort of thing. Costs more, but change agents pay off a lot. But those are designed. Those are all designed elements here, intervention. So that's just to get them to attend to it. And then they have to recognize the meaning of that change message and develop some intention to act. So what kinds of things? So imagine that we talk about change message. This is an important topic. It has potential substantial return on your investment and time, that sort of thing. And then, so we've raised anxiety in some, and then we're trying to translate that into some intention to act and take action.
You have to be able to see themselves doing it. Is this something that I could actually do?
What kind of visualize? Right.
They have to personally kind of say, oh yeah, I can do that.
Okay. So that's the next type of transition. We can, in fact, part of that is making the actions manageable pieces, right? You don't have to run a marathon tomorrow, but you got to get off the couch today. That sort of thing. So we look for high leverage, manageable, affordable, within the resources available actions to get to the next point. And then here's another thing. Anything that we're going to work on, they're not typically one-shot deals. You're going to be working on it for a while, right? The depression screening project, for a practice to get good at that, plan on making changes over the course of a year or so, maybe longer. And some of those changes, some of those actions they take will produce the results they're looking for. Some are going to be setbacks, some won't. And in every case, perhaps for our goal, the key is, what do you do? Do they persist in the face of setbacks? Do they exploit successes? So that's part of our design as well. And what can we do to increase the likelihood of this, exploiting successes? Well, what can we design into our interventions? Well, measurement is one of if we can help them institute simple measurement systems and they can see that they're having successes. If we can, persisting through setbacks, if we can let people know at the front end or when they've experienced it, you know what, you're changing the world. It's not unusual to have setbacks. We can learn from that and we can move forward. If they can see that, if they can be inoculated against those type of failures or maybe learn to interpret them as part of the natural process, then they're more likely to take action. And then ultimately, this project will end, G1 will go away, and then there'll be a 12th scope of work, or there'll be another project, and we're going to want to knock on the door of those same change agents again. I didn't appreciate this for a long time. Those people are still going to be there. Or even if they're not working with us, they're going to be working in healthcare and have an opportunity to make a difference. So we should be designing in ways that cultivate and retain change agents over time. So that when the next guy goes and knocks on their door, that that there's HealthInsight. Where have you guys been? So that's how I think that. So what do we talk about? Performance is a system property. A little bit of warning about how our position as a QIO or whatever, as a improvement entity, might set us up for underestimating the capabilities and the dedication and the committedness of our own customers, which is unfortunate, but we can be careful about that. Looking for in applied behavior analysis, recognizing the intrinsic motivators that the consequences as drivers of repeated behaviors, and using this to design interventions for recruiting, for engaging and retaining. So that's what we had for today. And there's references and other resources in the packet. So thank you for your time and attention today. And we have an evaluation. I hope you'll take the time to fill that out and leave it on the table over there. All right, bye.